Hi there, my name is Dr. Kate Gifford and I'm here to talk to you about the latest on atropine for myopia management as part of our Clinical Clarity series for Myopia Action Month 2025. Now the main detail that I want to go through with you in this short and sharp lecture is higher concentrations versus lower concentrations of atropine and what we know about the science. The first atropine study to be really notably showing impact for myopia control was the ATOM study, the atropine for treatment of childhood myopia. And the ATOM-1 study looked at 1% atropine versus a placebo. And if you have a look at the blue boxes on the slides there, they're showing you firstly how long the study was, all 2 years on this slide. Secondly, the absolute treatment effect in millimeters. And then the absolute treatment effect in diopters. So the millimeters and diopters are how much less those eyes grew or the myopia progressed compared to the placebo control group. So the 1% atropine study had a very strong effect compared to the placebo group. And what I want you to think about as a reasonable goal as I show you these slides is at least 0.1 millimeters per year of absolute treatment effect. And in that first 1% there, we can see it's 0.4 millimeters over 2 years, so 0.2 per year. That's a strong treatment effect. Now, the ATOM-2 study looked at 0.5, 0.1, and 0.01%. And interestingly, there was no placebo because 0.01% was meant to be the placebo. Plot twist, it ended up becoming a big focus of atropine treatment for many years thereafter. But what these studies showed us is there was a dose response. 0.5% and 0.1% had a significant difference to 0.01, but they appeared fairly similar in terms of their treatment efficacy. What we did learn from both of those studies, though, is that there was a significant rebound effect. So when children were stopped on 1%, 0.5 or 0.1%, they had a significant acceleration of their eye growth and their refractive changes compared to lower concentrations. There have been a handful of studies since which have looked at high to low concentration comparisons, and this is a series of studies, the same cohort, but there have been 4 papers published on this, of a cohort of around 100 Danish children. And these children were treated with 0.1% for 6 months as a loading dose and then switched to 0.01%. Now, in that first 6 months, they found that the 0.1% worked better than 0.01%. So have a look at the differences in eye growth and dioptric progression compared to the placebo group. And where you can see the X's next to the millimeters and diopters in the 0.01% box, that means it wasn't significantly different from the control group. Now, interestingly, the 0.1% did have some pretty significant side effects. Pupils increased by about 2 millimeters and amplitude of accommodation was reduced by 5 diopters. Compare that to the LAMP study where 0.05% only increased pupils by around 1 millimeter and only reduced amplitude of accommodation by about 2 diopters. So over the first 6 months, we appear to have a dose response again. Then they switched all of the children who were on 0.1% to 0.01%. And they found a little bit of a rebound effect. So the kids who had this loading dose, you can see that there's less difference between the groups now, between those second and third lines for millimeters and diopters. They caught up a little bit in comparison to the placebo-related change. And then something that was very important is that there was a big rate of adverse events. So there are 108 adverse events in 6 months. Almost 70% of the kids had issues like photophobia or allergy. And 0.01% by comparison had very few adverse events, only 14 out of almost 100 children thereafter after the first 6 months. In 12 months, after half of the children had been on 0.01% the whole time and half had been on 0.1% and then switched to 0.01%, there was no significant difference between the groups. So there was a loss of that initial treatment effect. We do have some data comparing lower concentrations of atropine to each other, 0.05% and less. And these two studies here, the LAMP study on the left, low-dose atropine and myopia progression, and another study looking at 0.02 and 0.01% on the right, have shown a dose response, meaning a higher concentration gives us a better overall treatment effect compared to the placebo, and lower concentrations give us a lesser treatment effect. Now, I found one study that looked at 0.5% to a placebo. This was undertaken in Chinese children with low myopia, aged 5 to 10 years. And this actually showed what appears to be no change in axial length or refraction over 12 months, which is pretty impressive. But we don't have any information about the rebound effects, which is the big concern with these higher concentrations. And also what was reported was just the baseline results and the final results, and not the differences between them, just the differences across the groups. And so we just don't know for sure if the changes over 12 months were significantly different. And we're also not sure of the measurement technique for axial length. If we're measuring by ultrasound, for example, that's nowhere near as accurate in gauging changes compared to measuring by optical biometry. There was a better study undertaken on 0.5%. This was in children in the Netherlands. And this particular clinical protocol that was approached is that if these children had significant progressive myopia, at least 1 diopter per year, and they're at least 2.5 diopters myopic, they were prescribed atropine 0.5%. All of them were also prescribed progressive edition spectacles with a +3 add, and photochromic lenses as well to be able to manage side effects. Now, these were pretty high myopes. The average refraction of these kids was just over 5 diopters, and the average axial length was just over 25 millimeters. Their mean age was around 9.5 years, but they were 5 to 16 years of age. And around 70% of them were of white European ethnicity. Now, what happened with this particular study is after 1 year, if they had a low response, which means progression of at least 0.3 millimeters per year, they were increased to 1% atropine. If they had a high response, so their axial elongation was less than 0.1 millimeters per year, the treatment was reduced. And the data, at least from what I can tell in reading the paper, is reporting all of the kids, but reports it as the kids on 0.5%. So we could say roughly on average, their mean concentration was 0.5%. What they found is that after a year, they were roughly divided into thirds. Around 1/3 continued on 0.5%, 1/3 needed to go higher, and 1/3 needed to go lower. On the upside, across the whole group, the average annual progression was only about 0.1 millimeters and 0.25 diopters. That's a great result over 3 years. But on the downside, there was around 20% dropout due to photophobia and allergy. So the tolerance level, and also thinking about these kids all needing a +3 add and photochromic spectacles, there's a little bit of a concern then in tolerance of the treatment. Now let's have a look at those absolute figures for 0.5% or the mean group over 3 years compared to MOSAIC 1 day in the middle and DIMS spectacle lenses at the bottom. And what you can see of those numbers is that they're not a whole lot different when we're looking at the absolute treatment efficacy of contact lenses or spectacles compared to 0.5% atropine. So 0.5% doesn't seem to offer better efficacy compared to our optical treatments, but it does definitely come with a much higher profile of side effects. We also know that rebound effects are significant in concentrations greater than 0.05%. In the ATOM-1 study, which looked at 1% atropine, 1 year of cessation saw these kids progress by over 1 diopter compared to only 0.38 diopters in the kids in the control group. Similarly, as I mentioned earlier, the 0.1% kids showed a rebound effect compared to the 0.01% kids in the Danish study over 6 months. After having 6 months of 0.1% and then changing to 0.01%, their eyes grew and their refraction progressed more quickly. The good news is the LAMP study showed us that 0.05% and lower don't appear to have significant rebound effects unless we're ceasing treatment in younger children. We wouldn't do that. We wouldn't want to cease myopia control treatment in kids 6 to 8, 9 to 11, or even 12 to 14 years of age as we're assessed within the group. Tapering makes a lot of sense, and also continuing treatment throughout childhood is what makes a lot of sense. What about 0.01% atropine? There have been a raft of recent studies which have looked at specific formulations and non-Asian populations of 0.01% atropine treatment. And overall, these numbers as well, you can see none of them are really making that goal of 0.1 millimeters per year. When we look at the treatment effects. One in the middle, the Apple study did, which is a little bit different to the others. The X's next to the numbers indicate no significant difference compared to the control groups. And if we have a look at 1 year or 2 year data, which you can see there again for MySight One Day or for dim spectacle lenses, we can see that these results, while we can't say they're significantly different, they seem to be better. They seem to be higher numbers with our optical treatments compared to 0.01% atropine. So the clinical utility of 0.01% is perhaps more so in combination treatments. There's a strong evidence base for ortho-K. There's equivocal evidence for MySight One Day and dim spectacle lenses in combination with 0.01%. Those are the question marks. And 0.01 combined with centre distance multifocals with a 250 ad didn't show a boost effect to efficacy, which is what that red cross is indicating. We do have some new data on 0.025% in combination with ortho-K and dim spectacles, and 0.05% in combination with ortho-K and MySight One Day. This is more so in kids who were not showing a good enough response to monotherapy treatment. And so this evidence is really building on combination treatments with atropine. And that QR code will take you to an article on Myopia Profile which talks about combination treatment in general. What the evidence tells us now in sum is that once we get to 0.05% atropine, stronger concentrations don't appear to show better efficacy, or if they do, it is at the expense of significant side effects and also rebound effects on cessation. When thinking about side effects from 0.05% and less, these appear to be similar based on the data that we do have, the limited studies that have been undertaken, although there is individual variation. I hope you've learned a lot about the latest in atropine. Thank you for listening, and make sure to stay tuned for all there is to help you learn right across Myopia Action Month.